Hello, and welcome to Conversations from the World of Allergy, a podcast produced by the American Academy of Allergy, Asthma, and Immunology. I'm your host, Dave Stukas. I'm a board-certified allergist and immunologist and serve as the social media medical editor for the Academy. Our podcast series will use different formats to interview thought leaders from the world of allergy and immunology. This podcast is not intended to provide any individual medical advice to our listeners. We do hope that our conversations provide evidence-based information. Any questions pertaining to one's own health should always be discussed with their personal physician. The Find an Allergist search engine on the Academy website is a useful tool to locate a listing of board-certified allergists in your area. Finally, use of this audio program is subject to the American Academy of Allergy, Asthma, and Immunology Terms of Use Agreement, which you can find at www.aaai.org. Today's edition of our Conversations from the World of Allergy podcast series is targeted towards both medical professionals as well as the general public, and particularly patients who have food allergies. We are very pleased to welcome Dr. Douglas Mack to discuss a wide array of current food allergy information and perspective. Dr. Mack is an assistant clinical professor in the Department of Pediatrics at McMaster University in Hamilton, Ontario. Dr. Mack is a member of the board of directors for the Canadian Society of Allergy and Clinical Immunology, and his research and clinical interests are focused on pediatric food allergy and anaphylaxis, particularly on education and practical approaches to management. Dr. Mack, thank you so much for taking time out of your schedule to join us. Welcome to the podcast.
Hey, thanks, Dave. Thanks for having me. I really appreciate the invitation.
I think this is going to be a great conversation.
Totally.
And as as our listeners will hear, so much has changed just in our understanding of food allergy. But before we get to some of the specifics and questions, Food Allergy Awareness Week is taking place between May 8th and May 14th this year. And it's always in May every year. What does this week mean to you?
Well, I think, Dave, traditionally, food allergy has had a bit of a low profile, I would say, in the medical field. And I think often there's an underestimation of some of the challenges faced by many of our patients and some of the dangers and some of the approaches. And I think this week really, I hope, not only increases the awareness amongst the general population, but also amongst physicians, so that they understand kind of what our patients go through, and even considering challenges like the top 10 challenge, where, as a physician or as a trainee, I like to get our trainees to kind of pick a food and say, if you had to live like a patient who had food allergy, how would that feel? And so we often will kind of do that and say, what does my day look like when I'm trying to read labels? So this is a tricky thing, and I think food allergy has a burden that is really quite substantial for our patients. So this week, actually, I think is great. It's a great opportunity to educate our community.
No, that's fantastic. I couldn't agree more. Educate the community, support and advocate for our patients. There's just a lot that goes into it. And as part of our efforts to raise awareness, can you just give us some background regarding food allergies, including what are some of the more common food allergens, the types of symptoms that typically appear, and really how they're diagnosed?
Yeah, well, this is, I mean, at its core, this is, all of us should be able to tolerate the foods that we eat, and food allergy is fundamentally an immune reaction towards specific foods that really, once again, should be tolerated. So the reaction can be quite mild, but it could also be quite severe. And many patients and listeners may be familiar with anaphylaxis, where a patient may have difficulty breathing, may pass out. But many patients will include just simply hives, vomiting, etc. And it is an immune response, and that means we can test for it. It also makes it a bit challenging for us to manage in the long term. But some of the foods that people often think about when they think about being able to react to foods would be foods like peanuts, milk, wheat, eggs, and our adult population, certainly shellfish, other fish as well, from finned fish like cod or salmon, sesame seed, mustard. These are kind of emerging allergens as well. So these are foods that you're going to find in so many foods that we eat on a daily basis, that for the food allergic individual, eating these foods can lead to, once again, a mild, moderate, or severe life-threatening reaction. And I think that that's the challenge that all of our patients face, is that they are faced with this. And think about it, we eat how many times a day? I think this is not something that is readily avoidable. We eat, it's a huge part of our culture. And so the risk for reaction certainly is something that our patients feel on a regular basis.
When you're talking to somebody who has concerns about a new food allergy, are there parts of the history that you really focus in on, like the type
Totally.
of food or reproducible nature of symptoms? Tell us a little bit more about that.
Yeah, absolutely. So there are Once again, the foods that we mentioned are some of the more common ones, and I think that we often look for common allergens being a trigger. The time course. So, for example, if somebody is eating a food and then has a possible reaction 8 hours later, I'm much less inclined to think that that was a reaction compared to somebody, for example, who had it ate a new food and reacted within 5 to 15, maybe half an hour. So the time course is, I think, actually really, really important. And the generalizability. What I mean by that is, in general, we see that patients don't develop 20 new food allergies at once, but they also don't have a part-time food allergy in general. So, if somebody
Mhm.
is eating a food and they can eat it again in a substantial quantity without reacting, well, chances are that that food is not causing a reaction. So the time course of this is very key. The reproducibility of it, and then the characteristics is this a food that's likely to cause a food reaction? And I think all of those go into forming our diagnosis. They're never 100%. I mean, there are some weird and wonderful foods that we see that certainly an allergist needs to deal with, no question. But we always look for the common things initially, and look for patterns.
Yeah, so focusing on the history, and the analogy I often use with patients is we do want to clarify what's an allergy versus symptoms for other reasons. And
Hmm.
I always talk about beans because they really are the magical fruit, right? So people
They
would eat a lot
sure
of beans.
are.
You may have more gas. It doesn't mean you're allergic to it. You
Yeah, no
absolutely have symptoms
question.
from it. It's just normal part of digestion.
Absolutely.
Um, are, so moving on to misdiagnosis. Are food
Sure.
allergies frequently misdiagnosed, and if so, why is that?
Well, I think there's two sides to this, and I think you've kind of alluded to one of them. Is the digestibility, the ability to break down the sugars in the food. So we have intolerances, no question. I mean, people have a hard time digesting milk. That is not a milk allergy. That's called a lactose intolerance, and that's purely digestive. It is not an immune response. It is not life-threatening. The same thing happens with foods like beans and other types of foods. In fact, even wheat. People often think about gluten intolerances, and absolutely, there's celiac disease and other ones like this. But even wheat has sugars that for many patients are hard to break down, and they often feel quite a bit better when they remove them from the diet. And that is, these are digestive intolerances, and I think that that's one side of it. So there's that kind of you know almost watering it down to, because these are, people often think, well, I have a milk allergy too. Well, you don't have a milk allergy, you have an intolerance. And I think that can be difficult for our patients to kind of explain from a schooling perspective or restaurants. But then there's the other side. I think that where there's overdiagnosis, and I think that that's very challenging from my perspective. And I think that that's come because of the widespread availability of what we call serum IgG or immunoglobulin G testing, kind of looking for your food intolerances. But even as us as clinicians, we often will perform batteries of tests that may not be terribly specific or terribly precise. And what I mean by that is, for example, if somebody has a reaction to milk or a reaction to peanut, sometimes what allergists or other clinicians will do is they'll order blood work or skin testing for 10 or 15 different foods, when the history, as we've talked about, is so key. So, hearing that history really helps me to focus. I mean, I don't like to test for foods that have never been eaten, or that foods that have not, were not eaten or reacted to as part of that process. So, trying to keep that accurate, based on the history, limiting our testing, and then following that up with further diagnostics. I mean, that to me is the key. So yes, I think that there's an overcall for kind of milder intolerances, but then there's also an overcall because we simply, unfortunately, have um, you know our tests are not perfect, Dave, and you know this. I mean, I think that these are probability tests, and what I mean by that is, you
Mhm.
know these are not severity tests. These are not yes or no's by any means. I mean, I
Mhm.
think that in general, the bigger the test, the higher the probability that a patient has an allergy. But unfortunately, every food can have a different level of testing, where we say, an 8 millimeter test for this food may be a bit different than for this food to predict how probable this is. But once again, at the end of the day, regardless of my blood work, regardless of my skin testing, what a patient tells me in that room is so key. And if I'm not listening, and if I'm not kind of really teasing that out, I see misdiagnosis all the time. I've definitely done it myself. I mean, I think this is just unfortunately part of the diagnostic uncertainty that exists. And I think, we can also talk about, food challenges and how do we utilize those. But in the end, a food challenge is where you give a patient a food that they may or may not react to. That to me is in general the gold standard test. That's once again, what happens when you eat the food is far more important than what happens on my skin test or in my blood work.
I think that's great advice. If I may, we're just getting going here, but I'm going to put you on the spot early. And
Yeah, love it.
if I gave you a billboard and you could
Yeah,
put this billboard next to every major highway that
sure.
everybody would see, because they're going to drive past it, and regarding food allergy testing,
Yeah.
what message would you put on the billboard?
I would love just a big stop sign that says no, stop the food panel testing. I mean, I think that includes, food panel testing with IgG testing, immunoglobulin G testing, but also what we do as well, where we kind of just, like I said, where we come into the office and we test for 20 different foods. To me, that is not good medicine. And I think that is, that's a hard stand to take sometimes. And I think that this is something that has been done in the past. And once again, this is how we were trained. I mean, 15 years ago, this is what we were doing. But panel testing, once again, some of our tests, I mean, I can flip a coin and have better diagnostic accuracy, in my office. And so our tests are good to a point. But I think in the past, the food panel kind of allowed us to say, well, just avoid that food, just avoid that food, and just avoid that food. We'll test you again in 2 or 3 years and see where this goes. Well, the problem with this, Dave, I mean, we've had so much data now suggesting that unnecessary avoidance of food that you can tolerate is actually harmful. And I don't think we had that data 15 years ago. And I think it was okay to say avoid at that point. Now, we want patients to avoid the foods they are allergic to, but for the foods that they aren't, they really should not be avoiding these foods. And I think that, unfortunately, a panel test where we test for 10 different foods and we get, a little bit positive blood work, a little bit positive skin testing, and the patients end up avoiding it. Well, that can itself lead to unnecessary avoidance and unnecessary development of allergy. And I've seen it in my clinic, and I'm sure I've contributed to this as well. And I think that that's a challenge. And I think that, once again, avoidance it's kind of almost use it or lose it, and I think that this is something that I, talk to my families about. Yes, I understand that we tested for this, or this has been tested for, and it did show a very weak positive test, but we need to make sure for certain that you aren't allergic. And unfortunately, a panel test just really sets up this kind of expectation of multiple allergies in many scenarios. And that for so many patients has just been a very, very harmful pattern. So yeah, stop the panel food testing is what I would say.
Stop the panels. I like it.
Stop the panels.
Hopefully that won't cause traffic accidents as people think that they actually
stop. Yeah,
right. All right. So you very eloquently discussed why we really don't want to, misdiagnose and overdiagnose and remove food if we can avoid it. But when somebody does have a food allergy and they do need to avoid a food, how do you help families learn self-management skills at that initial consultation?
Yeah, this is tricky, and I think probably not necessarily as well as I should be, to be honest with you. Sometimes I think that we always talk about what foods that they need to avoid, but also kind of make sure we make a plan to introduce the other foods of concern. That's really very important. We always talk about an anaphylaxis action plan, kind of, how to use your epinephrine auto injector. We have trainers that are in the office, which are nice, and have videos that parents can watch, etc. And so that's an important part. What are the symptoms that we might see, and how do we treat that? And with the number one medication being epinephrine. I do like to use patient support groups. We have a great one in Canada called Food Allergy Canada. They provide a really balanced approach to managing food allergy, which I really like. I mean, I think that they've put risk into a very nice perspective, and so I really, I love those. I know you have those down south as well. Once again, epinephrine auto-injector training is important. And then for our kids who have multiple food allergies, I love to use pediatric dietitians. I think this is a resource that I think is I think we're going to see a lot more of these being used in the future. We're trying to get some training programs to train our dietitian to be specifically well versed in food allergy. And I know that this is something that some of our colleagues in the States have been working really, really nicely on. Karina Venter and Miriam Grouch, et cetera. So these are people who are doing some really great work in the U.S. about trying to train our dietitians. But I think that educational component it's never it's never satisfied in that first visit, and I think that often we will have families coming back with lots of questions, and it just sinks in, it sinks in with time, and your perspective changes with time. And I'm always amazed by the fact that I'm sure I said this thing because it's what I say all the time, but not everybody hears what you say. And I think, unfortunately, there's a lot of misinformation on the internet, and I think, so I try to tell them, if you have questions, come back to me, ask me, email me, and I'm happy to answer them. The stuff on the internet, you have to be really, really, really careful. So I think those are some of the skills that I try to train, but it's an ongoing process, believe me. And as you know, this is not something that you can deal with in a 15 half an hour discussion. It's an ongoing thing for sure.
No, I really like a couple of aspects of what you pointed out. Of one, it's ongoing education, so
Mm,
follow-up visits, being open to questions. Two, multidisciplinary, involve your entire staff to help with
mhm,
education and training. And then three, give them resources, because after
mhm.
they leave our office, they need information, they need support,
Yep.
and we can provide them with vetted resources so they can hopefully avoid the misinformation.
Yep.
And
Agreed.
what I
Totally.
didn't hear you say, I'm sorry, I didn't hear you say, don't send your child to school. You can never go to a restaurant again. You don't
Totally.
get on airplanes. But we have common questions. So how do you counsel families when they have concerns about accidental ingestion, casual exposure, or
Mm.
contact with the skin? What do you talk to them about?
Well, I hear this quite a bit, and I think that this is, I hear people talking about, airborne allergy or kind of contact allergy. Well, as you know, Dave, the first thing we do when we do a skin test, that is a contact exposure. This, the skin
Mhm.
test that we do in the office is actually a contact allergy, contact reaction, and so, by definition, patients can have. The good news is, and I think this is so 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 important, and I think liberating for hopefully for so many families, is that severe reactions are really dependent on ingestion. So eating these foods is the key here. Whether it touches their skin, that's very unlikely to cause a reaction. But accidental exposure, I think, is one of the more challenging things. By eating it is one of the more challenging things. And I think, listen, kids can do really very well. Families can develop amazing coping skills and strategies to help them to live a very, very normal life. I think so many of my families can live, nearly normal lives where they can travel, their kids can go to school, they can have, get together with families, but they still have to maintain a level of education about kind of what the risks are, and then develop strategies for avoidance. So, for example, if they're going to a restaurant, they typically, some families will pick very specific restaurants that they have a good communication with. They'll kind of talk to the chef, they're going to talk to the owner and say, look, my child has this, is this something that you can accommodate for my child? And I think so many restaurants these days are understanding that, and they're making those allowances, and they're kind of having those discussions. Many of them have, the actually relevant allergens posted on their website or posted on the menu. I've even seen this, on the menu, and so right underneath the food, so that you can kind of have a really good educated discussion about this. So, I think preparation, I think for these families is key, but an understanding that being in a restaurant where there is that allergen is not, simply being there is not going to lead to a reaction. And I think that's, that is something that I think is so important. We actually will, even for families that are concerned about this, we actually will have them. There was a great study that out of Colorado that looked at in-office desensitization to food, and it wasn't oral desensitization. What they did is that for families that were concerned that simply being, near a jar
Mhm.
of peanut butter was going to lead to a reaction, what we do, and we do this as well, is we have families come in and they will we'll put the peanut butter jar, on the bed away from the child who's sitting on a chair, and then we'll kind of bring it to the desk, and then we'll kind of open up the peanut butter jar, and we can move it closer and closer, and even if they're willing, apply it to the skin, and kind of show them
Hmm.
that these are that simply being in the vicinity of these foods is not going to lead to a significant reaction or any reaction at all. So I think that is a patient specific kind of thing that we'll consider, but I think it's really an important educational and therapeutic, to be honest with you, technique for sure.
I couldn't agree more. I have similar experiences. I started calling it exposure therapy
Yeah.
sometime last year. Of just I'm exposing you to situations that have caused all this anxiety and concern, and I can show you exactly what will happen, which
Hmm.
is more often than not absolutely nothing. And I don't remember which one of our colleagues said this at a talk I attended years ago, but I thought it was very helpful. Of with anxiety
Hmm.
related to food allergies, there's a healthy level if it reminds you to read labels every time, to inquire about ingredients, to have your epinephrine with you at all times. That's a healthy level of
Yep.
anxiety, but it can often, unfortunately, tip the scales and become very unhealthy if it causes undue fear, prevents you from participating in social engagements or dining out or things like that. So I think you summarized that very well.
Totally
Well,
agree with you.
moving on, a lot of what we're going to discuss during the rest of our conversation is going to offer some new perspective regarding multiple different aspects of food allergy management. How do you help families understand that the information you're providing today may differ from what was discussed just a few years ago? You sort of already alluded to this, but how do you
Mhm.
actually, tell families that things have changed?
Yeah, honestly, I think I think for myself, constantly, I'll just say personally, we constantly are trying to read and learn as much as we can. One thing I love about medicine, and one thing I hate about medicine, is that there's always new data, and change is difficult for us. You and I know that trying to change even our colleagues' ideas as to how to approach certain problems and challenges can be challenging. Um, but we have to constantly have the humility to understand that, unfortunately, we can only make the decisions based on the data that's there, and be able to kind of look back and reflect and say, yeah, you know what, that was not the right advice. I think the biggest example of that was, a few years back, when for years we had been telling families to avoid peanuts, to prevent peanut allergy. And we then had the LEAP study, which definitively showed that early introduction in an infant was actually protective. And if you think about it, Dave, it was the intervention was simply doing the exact opposite of what our guidelines recommended at the time. That's, and I think that we have to have that humility, and we have to always be looking at that, and we have to understand that that's going to unfortunately make some families feel a little bit insecure in our recommendations. And
Mhm.
absolutely, I totally get that. But there also is going to be, I think, some anger. I think that I have an upset and emotion behind that. I have families who, you know, quite specifically followed that recommendation, and it may have contributed. I mean, I don't think it necessarily caused, but it may have contributed to the development of their child's allergy. So, we have to take it, and we have to say, you know what, we were wrong. We continue to try to learn, and we try to modify. But unfortunately, what I recommend now, and to be frank with you, in 10 years, maybe even a different discussion, and the nuances of this, I think, are just, we have to have the research. And I think that's why Food Allergy Awareness Week is so important.
Mhm.
Getting funding for research, and trying to increase this exposure is so key, because otherwise we're just left with, what is your opinion, I mean, in the end, it's, if we don't have the data, we can't make the recommendations.
Do you think that a culture of fear has existed surrounding food
Mm.
allergies? And if so, what has contributed to that?
Yeah, I mean, that's a really good question. I think it actually speaks to kind of exactly what you're talking about before. The healthy anxiety, and I think absolutely, this is exactly, if you talk to any counselor or psychologist, there is always a healthy degree of anxiety that is protective. If I have a teenager who doesn't care about their food allergies, and out is doing whatever they want to do, and whatever, I mean, that's, there's no anxiety, then that's actually harmful. But you're right, it can be a little bit, unfortunately, extreme in some families and in some patients and even in some physicians. And I think that natural protection that's in absolutely all of us, I think, can contribute to that. And for example, thinking that a much smaller amount of food that could contribute to a substantial reaction. Absolutely, it can, but the vast majority of patients will never ever see that. And I think that we now have data about thresholds where you say, what is the threshold for this patient? How much can they actually eat? And not everybody is the same. And I think that there are certainly some extremely severe patients out there. But in general, trying to talk about the reality of what this actually looks like, I think is our job, in trying to put that into context and help families understand that. And I will tell you, I use a food allergy counselor routinely in my practice. And I think that that's somebody, there you can get counselors, psychologists, whatever, but I think somebody who is well-versed in understanding food allergy is invaluable in my practice. And I'm sure, in yours, but the problem is there's just not that many of them. And I think that that's one of our, once again, let's make this more aware and get people to do this.
I noticed throughout the pandemic that this concept of risk really is difficult for a lot of people
Very
to
difficult.
understand and communicate, and it made me think of food allergies. Do
Totally.
you feel that we've done a relatively poor job communicating and understanding risk to patients and families, and that they in turn have also don't really understand risk associated with various scenarios? Do you think that's part of it as well?
No question. I think this is the same in literally every disease, and I think that with food allergy is no exception. And it's challenging. When you look at the actual data, what is the risk of fatal anaphylaxis? Yeah, maybe around the same risk as getting struck by lightning. And I think that is that's a kind of a concept that we can put out there. Telling that patient that was struck by lightning that it wasn't risky being out on the golf course at that time. And the same thing applies for food allergy. The families often will say, well, what if my child is that 1 in a million or 1 in 100,000 or whatever else, and I think that's always at the back of this. But I think that the discussion about what is the actual risk, what is the perceived risk. And when I talk to families, I think that the perception of risk, if you were to ask families, how many think that their child will have a fatal anaphylaxis, it's far higher than what the actual risk is. And our job is never to say, hey, your views are not valid, or that this is not I understand why you think that, but let's just talk about what this really can look like. And then more importantly, let's talk about strategies to reduce that risk and mitigate those factors. There's never a zero risk scenario. And in fact, I often talk about risk stratification as if you're driving on the highway, 150 kilometers, or what is that in miles, like 90 miles an hour. That's a far riskier endeavor than driving at 50 miles an hour or 100 kilometers an hour. And we do this. We may go. I don't go 150, but I may go 10 kilometers over the limit. Some people would say that that's too risky. Some people should say that I should go a little bit slower. But whatever. The reality is, we all stratify our risk. We all stratify kind of what we consider an acceptable risk. It doesn't matter what scenario this is in, and food allergy is no exception to that. We have to be prepared. We have to talk about the risk, and I'm more than happy to talk about that with our families.
Oh, I think that's great. Are you a baseball fan, Dr.
Yeah,
Mack?
I love the Jays. Yeah.
All right. Oh, yeah. So yeah, Toronto Blue Jays. They play professional baseball relatively close to where you are.
Absolutely.
And I noticed that they promote allergy-friendly games where peanuts aren't served, or they have special sections without
That's
nuts. Is this medically necessary to keep people with peanut allergies safe while attending a baseball game? Like, do we need to tell people, unless they are not serving peanuts, you can't go watch the Jays play? Or
No, it's not medically necessary, and we have loads of data now to show kind of what, how far does peanut allergen spread. If you're shelling nuts, it actually drops very, very quickly and doesn't tend to spread very, very, very far. And the patients really, once again, we talked about ingestion, really have to eat that. But I think it's a really nice gesture. I'll be honest with you. I think for people like the Jays and other sporting events to kind of tell our patients and our families, they listen, we understand, we hear you. We know that for many of you, this is a very uncomfortable scenario. So having these kinds of exceptions, I think, is a really lovely approach. But I do want to, let people know, and my patients know, that is great. Take advantage of it if you're able to. But you can also go to a Jays game and be very, very safe without having to sit in those sections or have to only go on those days. And I think that, for example, we often think about peanuts, but I think, listen, I deal with patients with not more than just peanut allergy, tree nut allergy, milk allergy, sesame allergy, egg allergy, shellfish allergy, and we often kind of focus on peanut as being the number one risk factor, risky food. But so many of my patients have quite severe reactions to other foods, and they have to navigate that without the same considerations that our patients with peanut allergy get. So I think, look, it's a lovely gesture. I really, commend them for the understanding that this is hard for our patients, but I want to make it clear that that is not medically necessary to keep our patients safe.
This makes me think we have the Columbus Clippers where I live, so AAA affiliate. And I went to a Clippers game with a bunch of physicians, large group of us, and there were 3 children there who all had peanut allergy. And I remember they're all sitting near me in a row, and people were shelling peanuts near them.
Sure.
And there was no concern. They did great. And then it came up of how none of the parents brought their epinephrine with them. And then they all looked at me and said, "Well, Dave's here. He's the allergist. Tell me what to do."
Well,
I said, no.
Well, see, that's more risky, isn't it? I mean, that's far more risky, not having the epinephrine auto injectors. I mean, I think that, that this is part of the navigation that we need for our families, is to ensure that they are prepared, and that they could attend a peanut free, nothing peanut free game, and they don't have their epinephrine auto injectors. Then I think that's a far riskier behavior, because we need that, and that's one of the risk mitigation strategies that we love to talk about.
Yeah, absolutely. Yeah, we chatted about that a bit.
Yeah, I would. Well, that's a good teaching moment, isn't it? Yeah.
Yes. Many countries require very clear labeling on their packaged food products if they contain common allergens that you mentioned before, such as cow's milk or egg, peanut, etc. But more and more labels say things such as may contain, or processed in a facility that also includes, or shared equipment, or there's 20 variations of this. How should people with food allergies interpret these precautionary labels?
Now, that is a very loaded question, isn't it, Dave? I mean, I think that, it's I'll say cover your butt, packaging for so many companies, because may contain label, it's voluntary, and so they can put that on any food that they want. And I think that that's what we're seeing, is that, in the past, a may contain meant that it actually could contain, and now we're seeing this it's on. I see coffee beans that may contain shellfish, and there's how many coffee beans have you seen that could have shrimp on it? I mean, it's just I can't imagine I've ever seen anything like that before. So you see that, but then you see foods that are actually higher risk that don't have any labeling at all. And I think this is where the challenge is. The nice thing about about labeling is that if it does have that food in there, it has to claim that it does. So, for example, if milk is in the product, it has to say it has milk. If it's known to have it as part of an ingredient, the may contain, I think, is a real challenge. And I think that I love what other countries are doing with Vital, which is a voluntary initiative where they look at trace amounts and say, look, for this amount of food, we will put on a contain or may contain label or whatever. But for if the food only has less than a very, very small amount, which is not going to cause a reaction in nearly everybody, they don't have to have that label on there. And I think it does simplify things for many of our families, in many ways. I mean, there are some controversies about how to best do that, but it does reduce the kind of, well, now my kid can't eat anything because everything has a label on it. And I think that that's one of the challenges. You have 2 loaves of bread in front of you. One of them says may contain, one of them says does not. The one that says does not could actually still contain, and I think that it just wasn't put on there. And I think that that's our challenge. So I think having some degree of standardization is important. Now, I also think we have to use a bit of common sense as well as patients, and I think that, once again, this is talking about risk stratification, and there are higher risk foods and there are lower risk foods, and I think that some of our higher risk foods, as not shocking, chocolate bars, ice creams are higher risk. Baked goods. We had a recent article that we published that showed a very wide variety of peanut allergen in baked goods from a variety of bakeries that used peanuts, and some were incredibly small that would never cause a reaction in just about anybody, but also ones that would cause reactions in more than 50% of people, and I think that so there is some variation. So people do have to use some degree of judgment in that. Granola bars, I mean, anything from Costco. I mean, like, Costco was snack aisle. I mean, like, like how many Lara bars have I seen that have caused, anaphylaxis, or nut butters that the kids have for the first time when they're sitting in the buggy eating their food. I mean, this is a I'm not trying to slam them, but so many of those foods have these foods. So anyways, I think their families have to kind of really look into it. They have to use some degree of common sense. I have many families that will contact the manufacturer and say, like, well, is this a real risk, or is it just something that you've put on it as a label? And actually, major companies are willing to kind of have those discussions, and then go from there. I think in the end, it's a challenging thing. I have some families who feel better and navigate the world better by avoiding anything that says may contain. It's not wrong, and I think that's, if I were to tell two families, I have one family that's very nervous, one family that's not. Neither of these have wrong approaches, but one would say I would have a worse quality of life avoiding everything that says may contain. The other family says I would have a worse quality of life not avoiding everything that may contain. And both have a very reasonable perspective on this. And I think they are dealing with what they can deal with to reduce risk, and live as normal of a life as possible. And I don't think either approach is actually necessarily incorrect. And so I think that these are discussions that we have to have. I think in the past, I was much more rigid. I'll be frank with you. If it says may contain, avoid. I think we have to have some discussions about what does that risk actually look like.
Well, I'm going to ask you an even more loaded question here
Yeah.
in a second, but I do want to touch upon something you mentioned of, who are we to tell anybody what to do? It's
Yeah.
our job to help guide them through and to
Totally.
help them understand risk, and then they make decisions that, they feel best in their life, implementing. So along those lines, what do we know about individual differences in the amount of a specific food that will cause any reaction or even anaphylaxis? Does
Yeah.
everybody with a particular food allergy have that same risk from eating trace amounts? And if not, how do we help people understand these differences? So
Yeah.
now
I
we're
mean,
really getting into the weeds.
yeah, I mean, this is an evolving field, and I think that the concept of thresholds. I mean, if you think about this, every patient that I see will react to the food at a different level. Okay, so what I mean by that is, so say for example, just think about milligrams. If somebody has a milligram of a food, a very small amount of that population will react to that amount of food. And if you had 400 milligrams, 50%. But so what, in context, what I mean by that is, so for peanut, about 85% of people can eat about a tenth of a peanut if they have a peanut allergy. I'm not saying go out and do that, okay? And about 50% can eat about a half a peanut, approximately. I mean, these are just kind of approximate numbers. But what that says to me is that every patient does have a different level of sensitivity, and that level of sensitivity can actually change, and it can change based on the vehicle of the foods in. It can depend on the health of the patient at the time, and so this concept of thresholds. If 1% of the population will react at this level, 50% will react at this level. What is a reasonable level, et cetera? Is there a reasonable level? And I think these are discussions that, once again, we would never have had these discussions 10 years ago. And I think this is going to start shaping our policy, for example, our precautionary food labeling. But I think it's also important for our families to understand that. I think that if I talk to families and say, what how much do you think it would take to cause your child to react? Many will think that even like a light dusting of peanut, in something would cause it. And for almost nobody, it would cause a reaction. Almost all patients could do that. I'm not saying go out and eat all these kinds of foods, but the threshold is much higher, I think, than most people would think. Like I said, would anybody estimate that 50% of patients can tolerate approximately half a peanut? I mean, that's far more than I think the perception is out there. Like I said, not endorsing trying that, but there are people who do this. I mean, so what we will do is we'll do a threshold challenge. We'll say, listen, come into my office. We're going to do a single dose threshold challenge and see kind of, you can stratify what is your child's threshold. And now, once again, I have to use that with a bit of a grain of caution, because those thresholds can change. They can change if they have, asthma, or asthma that's not controlled, if there's an illness, even alcohol use, sleep deprivation. I mean, all these things can change your level of reactivity, even day to day, or even year to year. But I think it's an important concept to understand that it's actually typically more than most people think, and I think that's for better or worse. that's kind of where we are.
Right. And then it's not just in isolation either. So you pair that knowledge with, you
Hmm.
say, they think that their child's going to have a severe reaction from a dusting, and you can
Hmm.
demonstrate to them they can eat a whole peanut and nothing happens. It doesn't mean
Right.
they're not allergic. It doesn't mean they should
Nope.
go eat as much as they want. But then that informs their decision making regarding very low risk propositions, such as
Yep.
shared equipment labels processed in the same facility, even commercial grade peanut oil, things like that. So that combination, I agree with you, can really help and offer information
Hmm.
so that then they can, decide how they want to proceed from there. So I think this
Yep.
is where we're evolving to, but it does take a lot of time in the office. And
Well, that's right.
speaking of which, yeah, I'd love to hear your thoughts just on the value of oral food challenges
Oh
overall. When
man, this is I
I
love
know
it.
this is
This is
this
my
is your
beauty.
baby.
Yeah, it is. I love it. I
Yeah.
mean,
So
honestly,
when
Dave,
when are they
go ahead.
helpful? When should we do them?
Listen, Dave, honestly, food challenges, when I first started doing this, I would do probably one a day, and or if that,
Mhm.
and to the point where we would, pre-COVID, we're doing up to 12 food challenges a day in our office, and I think that this is because the importance of a food challenge. I don't think we can underestimate how important a food challenge is. It is our gold standard. Okay. And I think this tells me we can use this for food introduction if parents are concerned. It helps to clarify a diagnosis if there's been false positive testing. It helps us to decide whether a child is potentially outgrowing a food allergy. And so to me, food challenges are oral food challenges where a patient comes into my office and we start with a very, very small amount and we gradually increase it, have become the absolute cornerstone of what we do, especially even if we're considering therapies. We want to be, if I'm going to treat somebody, I got to be darn sure that I know that they're actually allergic to it. So, these are very, very important, and they're very, very safe. They take a lot of time from our perspective, a lot of energy, and they're actually can be quite nerve wracking for families. I mean, I think that there, and even for me, when I would do my first couple, even my first half a year of doing them, I was very nervous to do this. I'll be 100% honest with you. I'm sure you were as well. But 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 I think that families can be reassured. We absolutely see reactions. There's no question. We want to reduce the risk by ensuring that their kids are healthy, that if they have asthma, we actually have a mandate in our office that if they have asthma, they're on puffers beforehand, just to kind of reduce that risk. Not everybody does that, but that's kind of what we do. If there's any concerns, we just won't do it. But at the same time, reactions can occur. We try to reduce that risk. But in general, they're actually quite mild. And I think, that doesn't mean that severe reaction. I've absolutely seen severe reactions, in my clinic, and we've had to deal with them, no question. But thankfully, the probability of having a severe or even life-threatening reaction is very, very uncommon. And in fact, to my knowledge, in 50 years of having oral food challenges, there have been 2 fatalities. And we don't know all the circumstances behind those, but those are very, very uncommon and very, very unlikely, especially given the frequency of these and kind of how commonly they're being performed around the world. So I have to tell families, listen, these are very, very safe. They are so absolutely important. And I there are some doctors who won't do them. I mean, but for so many reasons. But I think, to be frank with you, you're missing out on a very valuable learning opportunity for our patients. And actually, it's interesting. What we like to do is if a patient does react during a food challenge, it's actually a good learning experience for families as
Mhm.
well. We'll have them. I tend to have the patient, if they're old enough, or the family, in fact, if they react and need to use epinephrine, they get to do the epinephrine, and that's a very valuable learning tool, to be honest with you, for our patients. And regardless of whether there's a pass or a fail, I almost don't use pass or fail, success or not, or whatever. you know there's actually an improvement in quality of life, whether there's a reaction or not a reaction. And I think that that's been well documented in the literature, where that even if a patient reacts, we still can see an improvement in quality of life, because now the family knows, and they can see how much the kid reacted to, and they can also see how well epinephrine works, because like it works really well. Like when
Yeah.
you see that kid in 3 minutes has gone from wheezing and hives to looking like a totally normal kid. I mean, it's an amazing teaching, and families will commonly say, wow, I just could not believe how well it worked. So overall,
Mhm.
I could probably, maybe that's my second billboard, Dave. I mean, I think, consider food challenges, because I think it is such an important part of what we do. And I think this is a trend I hope that our listeners will see over the next years, that this is becoming more and more common and done more frequently. In the past, like I said, it was kind of a, if I have to, I'll do it. Now it's kind of a must for us, to be frank with you.
Mhm. No, I appreciate your perspective. I share the same thoughts, and at our institution, we did over 900 food challenges last year.
Yeah.
I think, it's a valuable experience. We do the same thing if treatment is necessary. We walk the parents through it.
Hmm.
They do great. They always thank us afterwards
Yeah.
for that knowledge and knowing that they can do it and seeing how fast it works. Do you need to see completely negative allergy test results before you consider a challenge in somebody?
Not a chance. Once again, we talked about the fact that these are the skin test, the blood test, these are probability tests. When I do a blood test or a skin test, it's not to talk me out of doing a food challenge. It's to help me to stratify the probability of reaction, and that is it. And I think that is, we have kids who have had extremely large skin tests and extremely high blood work levels that have just sailed through, and they've done great. And the look of amazement on my face. I mean, not even my face, the parents' faces, and like we've had parents, in tears. They've lived, their entire life, as a teenager, positive skin tests for all these foods have been avoiding for, and then you do the food challenge, and they actually have no allergies. At the tears that you see, in those parents' eyes, it's actually, to be frank with you, it's so gratifying. It's one of my favorite parts of my job. I have to be honest with you, when we kind of delabel these families, these kids, get rid of those allergies, and just make a proper diagnosis. Like I said, I've seen a lot of tears and a lot of appreciation.
That's fantastic. You've published some really interesting experiences surrounding at-home food challenges or
Mm,
using like virtual monitoring and things like that. So,
yeah.
are there now we're really getting into the nuance of this. Are there low risk challenges that can be safely performed at home, and how do you
Sure.
triage those?
Yeah, I mean, I think that the when we kind of looked at this was looking initially at patients that were potentially at risk for developing peanut allergy. But what we
Mm,
did is we had them introduce it early at home in our infants, and we kind of supported our families. Early introduction of foods is so key, but I once again think that sometimes families will want to do that in office, and great, absolutely. We simply don't have the resources, and especially during COVID, we didn't have the opportunity to have every single kid do that in a medically supervised setting, and it's just not necessary. But that's a great example of a low risk challenge. Patients, for example, that have negative blood work or negative skin, or even low blood work or skin testing, have never eaten it. I often tell families, if that skin test hadn't been performed, what would you have done? You probably would have introduced that food. And so,
mhm,
when we have reassuring blood work, reassuring skin testing, there's never been a history of reaction. If a family's game, they're prepared. We've often walked them through, can you do this at home, et cetera. And I think that, like I said, if we hadn't tested, what would you have done? And I think that that's kind of a concept that I try to roll around in my head. We're looking at FPIEs, which is kind of a more interesting kind of food allergy, where there's kind of a delayed onset of vomiting. I'm not going to get into that, but that's another where that we're kind of looking at, can they do these safely at home? And I think that the
mhm,
answer is yes. So there are some very low risk challenges. Baked products for many of our families who have resolving milk or egg allergy. Many of these families will consider that. I don't recommend it for everybody. Once again, you need to talk to your doctor about when this is a reasonable approach. But for so many of our families, just getting those low risk foods in, um, you know, shellfish in an infant, or tomatoes, or these are very, very low risk foods. Just get them in. Tree nuts, same story. If you haven't had a reaction, I often recommend that as well. And that's commonly seen in patients who has a peanut allergy. Parents often say, should I introduce tree nuts? And my answer is yes. Get those
mhm.
in sooner rather than later. Do it cautiously, do small amounts, etc. But getting those in at home, I think is a resource sparing approach that I think is actually has long-term gains. So for sure.
Dr. Mack, this has been an extremely enlightening conversation. You've already provided just a wealth of information for us to consider during Food Allergy Awareness Week. If you're up for it, I'd like to finish with some rapid fire questions.
Yeah,
Does that
sure.
sound okay to you?
Yeah, I love it.
All right, here we go. First one. Do you recommend first generation antihistamines such as diphenhydramine or Benadryl, or second generation antihistamines such as cetirizine or Zyrtec for treatment of hives or skin rashes associated with food allergy reactions?
No Benadryl. Let's just be clear. And we actually have a position statement on this. Like that I put that in my presentations. I often put that as a slide as well, with a big, red circle around it with an X across it. No Benadryl. The reality is it's not a great antihistamine. It has a slow degree of onset, has a high side effect profile. And so cetirizine or other antihistamines that are long acting, second generation, are far safer, far more effective. I actually can't think of the last patient I ever recommended Benadryl. Good, love it.
So we need a billboard. We need
Yeah.
a blimp. We
Yeah.
need skywriting. I don't know. We'll get you whatever we can. All right, you're up for number 2.
Yeah, sure.
Okay. Is coconut a fruit or a nut? And do
Oh,
people with
Dave,
tree nut
this
allergies?
is going
Wait,
to be a
I'm not
quick
done.
one.
I'm not done. I'm not done.
Okay.
Do people with tree nut allergies need to avoid coconut right off the bat? Blanket statement.
That is an easy one. Answer is no. Okay. The reality is, coconut is probably what we call a drupe, which is, you can look that up, DRUPE. Like many of our actual, suspected tree nuts, like almonds and et cetera, these are actually drupes, not actually tree nuts specifically. However, the USDA, I believe, you guys have that in the States, it does classify it as a tree nut. Okay, what I will say to you is, regardless of how we classify this, the reality is, if people have a nut allergy, almost every patient can tolerate coconut. I only have a very few patients who have a true coconut allergy. It's very, very uncommon. And so it is fully unnecessary for the vast majority of patients to ever consider avoiding. And we would never, I would never test for that, in this scenario. So yeah, great question. Eat it, enjoy it. Pina coladas. For our adult patients over the age of 21 only. Yeah.
You're the first person to call me a name during the recording. I can't believe you called me a droop. That's very rude.
Yeah.
If somebody, all right, next question, if you're ready.
Yeah.
If somebody may have, not sure, may have eaten their allergen accidentally, but they don't have any symptoms at all, should they treat themselves with epinephrine and run to the emergency room?
I don't recommend it. I mean, I think for so many reasons, epinephrine absolutely is totally safe. It's our first line treatment when it comes to allergic reactions, no question. But it's medically unnecessary if the patient is not having symptoms at that time. And I think that that's an important thing to kind of really get through. In fact, if they have eaten, maybe they've outgrown it. Maybe their threshold is much higher than the amount that they ate, or maybe it wasn't actually in there in the first place. So I think that these are it's actually quite instructive. If someone says to me, I ate a peanut, he ate the whole peanut, chocolate bar and was fine. I think, well, I don't think, well, you should have used your epinephrine. I think, well, maybe he's not allergic anymore, and so that's, so I think it's actually diagnostically very, very helpful. I'm not saying don't, have your epinephrine ready, if you have it ready for sure. But the reality is, if there's no symptoms, I would recommend just observing for most of our patients.
Is there a possibility that the epinephrine would actually wear off before an allergic reaction actually even started?
It's a good question, Dave. It does actually have a relatively short period, around an hour or so of peak effect. But in general, most reactions are going to happen very, very quickly, within 15 minutes to 30 minutes. So the reality is, you're going to cover that in that time. So in general, I think you're good.
I hear from so many parents when, I talk about early introduction, they say, well, we haven't given strawberries yet because we know that they're a major cause of allergy. I don't know if you hear this in Canada, but oh my gosh. I don't even know where this started from, but set the record straight for us, Dr. Mack. Are strawberries a common cause of allergy, and do parents need to worry before feeding it to their babies?
I've never seen a strawberry allergy. We focus primarily on food allergy, and I have never seen a strawberry allergy. I actually don't know any clinician that I'm aware of that has actually seen a true strawberry allergy. I mean, it can happen, no question. You can react to anything, but strawberries can quite commonly cause rashes in children. They can cause a histamine release. They can cause an irritant response, a contact irritant. Absolutely, I see that all the time, but I have never seen a true strawberry allergy. So we'll set the record straight. It is not a major allergen. Introduce strawberries; they are delicious, and your child will not have a reaction. Yeah.
All right, last question along those lines. Can artificial food colorings cause true allergic reactions?
No, I mean, I think that they're the only kind of non-artificial one I've seen is for carmine, which is a very uncommon type of naturally organic food coloring. But for artificial, it's just about impossible for that to actually occur. You have to be able to form an antibody, and we just can't do that to those artificial colorings.
Yeah, this is a fantastic way to end the conversation. Thank you so much. And I'd like to finish with a prediction. So if you could dust off your crystal ball and look 10 years into the future,
Mhm.
what conversations are we going to be having then that we are not having now?
I think we're going to have much more precision as to what we do. So this will be, I think, a more precision-based medicine where we can say, okay, we have some diagnostic tests that are coming that look fantastic. We have, some treatments that are coming down the road. I think that there will be much more. You see the patient and you can make a decision based on that stratifying risk for them more accurately, and that's going to be part of our discussion, not just this kind of blanket avoid, which once again is already shifting. Active introduction of foods. I think that this is something that we may actually see that patients are not told to avoid. This is just my own kind of bent, but avoidance is maybe not the best answer for some of our patients. And I think that active introduction or active reintroduction may be something we kind of look at. We're going to see more food ladders where you start to kind of introduce less allergenic forms. Immunotherapies like OIT, sublingual immunotherapy, patch immunotherapy. So these are, I think, my feeling is we are moving towards more active treatment. And I love this. I love where we are because, when we got into this, we didn't have a lot of options for our families. It was really like we were kind of one-trick ponies, where we kind of said, "Yeah, this is what you have," and we kind of provide counseling on this, and we often would see them in a year or 6 months or 2 years or whatever, however you could do it. But we have way better ideas as to kind of what is the individual patient looking like and what are our options for them, beyond simply just avoid. Here's your epinephrine auto injector, and we'll see you later. I think that's. I love it. I'm so excited about where we're going, and I think our patients should be as well.
Oh, I hope that all of our listeners really, appreciate the passion that you bring to this. I know many others share your same passion and your message of hope. I mean, this has been a very positive
Hmm.
conversation. We're not telling people to run and hide and you can
Hmm.
never leave your house. And with your prediction, and I agree, and I hope that it comes true. It's going to get even better and better and better. So for everybody out there listening, whatever you may have heard 5, 10 years ago, there may be a new approach to you. And along those lines, the last question that I have for you is that I'm sure that our conversation today absolutely presented information that may be
Hmm.
very different from what some parents or patients have been told, or even advice from some of our
Hmm.
colleagues that they may offer. So, what advice do you have for everybody listening regarding how best to stay current with all of the evolving evidence and approaches surrounding food allergies?
Well, I think that, well, first off, doing your own research. I mean, like there is a lot of unfortunate, poor research on the internet, but the Quad AI, the American College, the other Canadian Society, we have some great resources that are available out there, and I think that they can provide some great, at least motivation for our families, and I think that's we try to stay as evidence based as possible. Once again, it will continue to change, but then having a good relationship with an allergist, that is consistent with current practice, and I think that having those discussions, finding out which approaches are good for you, and kind of what does that literature look like. And I think the reality is not. It becomes a bit tricky, right, when you're talking to about our colleagues, etc. And I think we're all going to have different approaches to this, different resources, different kind of understandings. None of us have the answer on how to do this, but being able to at least have those discussions and say, for you, these are some of your options, and having those discussions, I think if you're not willing to do that, that's kind of a red flag. But staying up to date, not neglecting to see your allergist on a regular basis, to kind of get that information, and I think that's key.
Do you mind? You mentioned a couple of times to be aware of misinformation. Are you active on social media, or where can people find you
Yeah,
if you'd like to
yeah,
share your handle?
absolutely. We're I'm at Dr. Doug Mack, MD, on my Twitter handle. We are expanding our social media presence through our clinic, Halton Pediatric Allergy .com. So we're working on that. It's how much can we do? But yes, I love social media. I love putting the facts out there, and once again, those facts may change with time. So
Dr. Mack, thank you so much for taking time to join us today. I thought this was a very enlightening and valuable conversation, and I'm sure our listeners will agree. Any last words before we depart?
yeah, no panel tests, no Benadryl, and the food challenge is golden. Yeah, those are my three.
Thank you again. We hope you enjoyed listening to today's episode. Please visit www.aaai.org for show notes and any pertinent links from today's conversation. If you like the show, please take a moment to subscribe to our podcast through Apple Podcasts, Google Podcasts, or Spotify so you can receive new episodes in the future. Thank you again for listening.